Okay, so psychopathology, very important topic. In the order of things to be covered, this should be covered pretty early because these are like the terminologies of psychiatry that you keep coming across. So you need to know the meaning and understand what they mean basically. Otherwise, it's going to be very tough for you in psychiatry. But it's very similar to having going back to your first year in medical college, you started learning about anatomical terms, right? Lateral, medial, superior, inferior, remember? So it's somewhat similar to that. Without learning that, you cannot go ahead and talk about complex conditions in psychiatry. So let's start. Psychopathology. There are two related terminologies, phenomenology and psychopathology. Psychopathology means the pathological terms associated with psyche, that is the mind. So it's the pathology of the mind, that's what we are studying. Phenomena are what happen in the mind, so it's also called phenomenology. So our main aim is to understand these psychopathological abnormalities, and it was Husserl who introduced the idea of phenomenology. Then another person called Dilthey stressed the understanding in psychology and to treat individual as a whole, not just mental aspects but everything. Jaspers introduced the concept, and he was very much like the founding father of psychopathological study, basically. Binswanger, on the other hand, proposed existentialist interpretive psychology, which is like an extension of treating the individual as a whole, and it is interpreting the signs and symptoms, the pathology of the brain, the mind, and trying to understand the patient's mentality and where he's coming from, the cultural concepts behind that mentality, the social aspects, everything. So it's like a holistic approach. So to make it easy for you, although these topics can be arranged in any way, I have arranged it according to the mental state examination, okay, so that it's easier for you to understand and remember. So as you know, in mental state examination, the first step is appearance and behavior, the attitude of the patient towards you, towards the interview, and there may be different abnormalities in attitude, such as indifference. Somebody may be not very interested in what is going on. Somebody may be angry and irritable, and therefore they will never engage with you when you go for an interview. So all these are different aspects of attitude. On the other hand, in somebody with hypomania or mania, they may be over familiar with you, and their attitude may be such that it would be a little bit overbearing for you. Okay. And rapport again is related to that. As I have already told you, it's the quality of interpersonal relationship. Specifically, it is the quality between you and the patient, which decides how good an interview or assessment you can do with the patient. If the rapport is very, very poor, engaging with the patient becomes very difficult. On the other hand, once again in mania, when the patient is over familiar, that may result in excessive rapport, which may also be somewhat problematic. So moving on to tics. Yeah, they're irregular, repetitive movements involving group of muscles. That is what they are. And according to what is involved in the production of tics, they may also be classified as motor tics and verbal tics. Let's just stick with the motor tics for now. So as I said, it's like involuntary repetitive movements of muscle groups, such as shoulders jerking suddenly, or the neck turning to one side suddenly, It can be seen as part of a developmental condition called Giles-de la Tourette syndrome, or simply called Tourette syndrome. Tics may also be associated with autism and obsessive compulsive disorder also. So, as I have told you, rarely it could be verbal tics in the form of grunting noises, or it can also be swear words. They have the irresistible urge to swear in public. That can also happen. We had a rare presentation of tics which presented like a cough, and the person was treated by a respiratory physician, but ultimately it responded to medication which is used to reduce the tics. So we published that as a case report. It was a rare presentation. Tremors, shaking of hands and legs, as the patient put it. So tremors can be fine or coarse. Coarse or much more visible tremors, whereas fine tremors you can't really make out unless you put a paper in the patient's hand and you can see the paper trembling, correct? So these may be part of medical conditions also, like hypothyroidism or hyperthyroidism. But in psychiatry, they may happen in response to anxiety or as a side effect of medications. So what's chorea? Not the country. Athetosis is the writhing movement, whereas chorea, it's like again a group of muscles, involuntary jerky movements, which may appear like some kind of bizarre dance, whereas athetosis is somewhat, there seems to be some kind of pattern to it, writhing movements, and it may happen continuously for a longer period of time. It's not very jerky as chorea. Okay, so chorea, one famous condition for chorea is, which also has the word chorea in it. Which one? Yeah, Huntington's chorea, which is an autosomal dominant condition, I think, isn't it? Whereas athetosis, any examples? Can be again part of genetic conditions, especially something like cerebral palsy. Dystonia, as the name indicates, it is abnormalities in muscle tone. Okay, usually the tone increases in psychiatric conditions, especially in catatonia, which is a feature of schizophrenia and also a subtype of schizophrenia. So increased tone can result in different kind of tonal abnormalities, as you already know from medicine, the rigidities, types of rigidities, clasp knife, cogwheel. One particular type of dystonia is called acute dystonia, which happens as a response to side effect of antipsychotic medication. It can happen within minutes of giving antipsychotic medication, usually given by the parenteral route. Classical example is if you give haloperidol IV or IM, the patient may suddenly end up with acute dystonia characterized by muscle spasms in the neck, back, sticking out of the tongue with hypersalivation, or rolling up of the eyeballs, opus totalis, torticollis. You have all these things. It looks very distressing, but it can be easily treated by giving anticholinergics, IM or IV, usually procyclidine. So that's that. Then moving on to stereotypies, they are repetitive, purposeless movements. So they are somewhat random, and even though the person does some action, it seems meaningless. You'll be wondering, why is he doing that? Like, could be like repeatedly adjusting the cap on his head or something like that. On the other hand, mannerisms, they are also repetitive, but they seem to have some kind of purposeful movements, like repeatedly saluting, for example. So that's the difference between stereotypies and mannerisms. All of these that I have mentioned, especially dystonia, stereotypies and mannerisms, as I have told you, can be a part of catatonic schizophrenia. So they are catatonic signs and symptoms. Compulsive acts I have included here, even though it's a part of OCD, because it's like a behavioral act, isn't it? Compulsive acts are things like what the patient does, basically, like repeated hand washing, repeated counting, repeated arranging and rearranging of objects, touching of objects, which can be seen in OCD. So, continuing with appearance and behavior, mitmachen. You will come across quite a few German terminologies here because, as I have told you, the early pioneers in psychiatry were German. You have something called mitmachen, which is like, even though you tell the patient to resist any passive movements that you are causing, the patient goes ahead and does the movement. Like, for example, if you are trying to flex the elbow and you say resist my movement, but the patient still does it anyway without any resistance, so that is mitmachen. Mitgehen is the extreme form of mitmachen, where even with a slight pressure the patient just moves the entire limb in the direction. So that is mitgehen. Clear about that? Gegenhaltan means opposition. So if you are trying to extend the elbow, the patient will resist the movement and try to do the opposite, flex. So that is opposition. Negativism is an extreme form of opposition, where if you instruct the patient to flex the elbow, he will do the opposite, that is extend the elbow. That is negativism. Ambitendency is a bit of both. The patient is caught between doing and not doing. Sometimes he follows your instructions and flexes the elbow if you have asked him to flex, and then he goes back to extending again. So that is ambitendency, fluctuating between doing and not doing. So mitmachen is a basic level. Extreme form of mitmachen is mitgehen. Gegenhaltan is the opposite of that basic level. Extreme form of gegenhaltan will be negativism. Caught in between these two is ambitendency, little bit of doing and not doing. Catalepsy is the tone abnormality, which is part of, again, catatonic schizophrenia, wherein the body can be maintained in some abnormal posture for long periods of time, and I mean for several hours sometimes. You can see this catatonic patient standing in some abnormal posture for several hours. And the type of catalepsy is flexibilitas seria, which is also called waxy flexibility, wherein if you just move the hand of the patient, you can put it in any position, like wax. You know, when the wax is semi-solid, you can mold it into any shape, right? So it is similar to that. You can sort of mold the posture of the patient into any position and just leave it, and he'll just stay there like a wax doll. So that is waxy flexibility or flexibilitas seria. Also, catalepsy, please don't get confused with cataplexy, which is different. Cataplexy is sudden episodes of hypotonia in response to some emotions such as laughter or crying or whatever, and the patient suddenly falls down because the tone in the muscles reduces drastically. That can be seen as part of a kind of sleep disorder called narcolepsy. So don't get confused with between catalepsy and cataplexy. Echopraxia, echo means repetition, praxia is movements. So whatever movement you do, the patient will copy you with that movement. If you touch your nose, he will also touch the nose. You understand? If you get up from the chair, he will also get up from the chair. So that is echopraxia. And stupor is a change in consciousness, basically, wherein the patient is alert, but he is not responding to any stimulus. He or she will be just staring at a point, not moving, and even though he or she may be sitting, apparently awake and alert, they will not respond to any sensory stimuli. Obviously not attitude, not rapport. Tics are a different condition. Tremors may be seen in catatonia. chorea, athetosis is very rare. They are part of different conditions. So from dystonia onwards, not compulsive acts also, because that is part of OCD. Dystonia, stereotypies, mannerisms, all of these, as I keep telling you, are part of catatonic signs and symptoms. And one of the subtypes of schizophrenia, remember, is catatonic schizophrenia. So all of these could happen in that condition. So as I keep telling you, speech is an expression of thoughts. So in the mental state examination, you can divide speech also, same as thought, that is stream, form and content. So based on that, you can have poverty of speech, which means hardly any speech. A patient is hardly speaking, even though you are asking questions. Where do you get that? Yeah, catatonia, and also somebody who maybe would be so downcast and depressed, and loss of involvement is so much that there will be poverty of speech. Sometimes in extreme severe forms of depression, you can have that second last one that I mentioned there, mutism, complete absence of speech. Pressure of speech is opposite of poverty of speech, wherein the patient cannot stop talking when you can't get a word in edgeways, and that is seen in the opposite of depression, which is mania. Perseveration, disorder of form of speech or form of thought, wherein the same theme is persevered with or repeated by the patient. They'll catch hold of one idea and they'll keep on talking to you about it. Okay. Circumstantiality, on the other hand, is over-involving, needlessly involving topic. Suppose you talk about the weather, today's weather. They will start talking about the weather in different parts of the country, the wind systems that are existing in the world, and have global warming and all sorts of things. And sometimes they may involve unrelated topics also along the way. I was coming out today, the weather was very good, but then I had to go to the grocery store to pick up something. So it sort of goes rambling kind of speech, which never gets to the point. That's what it is, circumstantiality. Maybe a feature of dementia, actually, circumstantiality. And of course, mania also, because they can't stick to one particular point. Tangengiality is they're talking about one topic and suddenly they go into some related topic. Like again, if you talk about the weather, they'll start talking about what they do during summer, for example. Or they may start talking about environment, global warming or something like that. So tangentiality is a related topic. But it's like going off in a tangent. That's what it is. Echolalia is the equivalent of echopraxia, which I mentioned earlier. This is to do with speech. Echo is repetition, lalia is speech. So whatever you say, they will repeat, like a parrot. If you ask them a question, they'll repeat the same question to you. Okay? Coprolalia, on the other hand, is swearing, using swear words, bad words, foul language, that is copro. Lalia is speech. So you get a lot of swearing, and as you might have guessed, you get that as part of Tourette syndrome. They have an urge to swear. Mutism already described. Mutism may be seen both in severe depression as well as catatonia. Dysarthria, muscles of articulation like tongue and palate. Dysphonia, vocal cord, recurrent laryngeal nerve palsies. Dysphasia, more central brain areas, Wernicke's and Broca's may be affected. Out of these, poverty of speech, echolalia, mutism, all these three can be part of catatonia. Pressure of speech, I've already told you, mania. Perseveration, circumstantiality, tangentiality, all of them can be mania or dementia, schizophrenia also. Coprolalia, Tourette syndrome. Mutism can also be severe depression, and all the other three, dysarthria, dysphonia, dysphasia, can be neuropsychiatric or organic conditions. Affect and mood. Affect is the variations that you see in the patient's expressions, emotional state in response to external situations. Like, for example, if I tell you a joke, you will smile or laugh. So that is a change in your affect. Mood is the more inner, pervasive, long-lasting emotional state which does not change too much over a period of time. So accordingly, you can have labile affect, which is frequently changing. Labile means changing. So the expression can change from in 1 minute from laughter to sadness to crying. That can happen in mania. Flattened affect is what it says. It's very flat. It appears very dull. So that can be a feature of dystonia or depression. Congruous or incongruous affect. As I have also described this also previously, congruous means it is in keeping with the situation. Like if I tell you a joke, you will laugh, right? So that is congruous, expected reaction to the stimulus. That's what congruous means. Whereas incongruous is opposite. If I tell you a joke, instead of laughing, you'll be crying. Okay? So that will be incongruous. Or laughing at a funeral where you're expected to appear very somber, you appear as though you are enjoying the situation. So that is incongruous affect, may be seen in schizophrenia. Euthymic is normal mood. Eu means normal, thymia is mood. So euthymic describes a normal mood which most of us have. Dysthymia is chronic, enduring low mood since several years. It may be a precursor to later depression. The chronic low mood is there, but it is not sufficient to, or it's not sufficiently severe enough to call it depression. Hyperthymia is the opposite of dysthymia, wherein it is chronic elevated mood. They are always very jovial, laughing, extroverted kind of people. But again, the severity is not enough to call it hypomania or mania. Cyclothymic is oscillating between dysthymia and hyperthymia. That means sometimes sad expressions, and after a few days they appear to be happy. So it's like a very, very mild version of bipolar disorder, but not severe enough to be called bipolar disorder. So when it does become a disorder, the mood can be depressed mood, which is seen in depression, of course, or it could be anxious if the person has an anxiety disorder, or it can be the two variants of elevated mood. Elevated mood means extremely happy, sometimes also called euphoria. Extreme elevation of mood is called euphoria, which is extreme happiness for no reason. So that is, one is hypomania, the other one is mania. So what is the difference between these two? Okay, hypomania is a milder form of mania. It's one step below mania. Hypomania, all the signs and symptoms, that is garrulousness, laughing a lot, talking a lot, sleeplessness, all that is at a milder level. Delusions of grandeur will not be seen in hypomania, whereas in mania you find all of these features, including delusions of grandeur. But one of the key differentiating factors between hypomania and mania is that in hypomania there is no socio-occupational disruption. That means even though the patient has hypomania, he or she can continue to work and have good social relationships. Whereas in mania, everything is lost, everything is disrupted. They won't be able to work, and of course relationship will be very difficult if you have full-fledged mania. So that is the difference. Thoughts stream, form and content, as I have told you. That's the way we study the thoughts in psychiatry. So thought stream abnormalities, what can they be? Retarded thinking, which is the equivalent poverty of thoughts, which is similar to poverty of speech, is it not? So you'll find a lot of overlapping terminologies here between thought and speech, which is the same basically. Hardly any thought in the mind of the patient, which can be seen in depression. Thought block, on the other hand, what is that? No, the patient is thinking about something but is unable to think beyond that point. Suddenly it's like the thought is blocked, basically. So that could be seen in schizophrenia. Thought form or formal thought disorder. So all these are the features of formal thought disorder. Perseveration, which is similar to perseveration of speech, wherein the same thought is repeated again and again. Circumstantiality, over-involving unwanted details in whatever the patient is thinking. Desultory thinking is what it says there, sudden unconnected idea, talking about one thing and suddenly jumping into a totally unrelated topic. So that is desultory thinking. Flight of ideas, it's like the ideas fly from one topic to another. And usually these topics are related to each other. So that is the key there. Like again, if you stick with the weather example, they'll start talking about today's weather. It's very hot and warm. By the way, the sun is so much distance from Earth. You see what I mean? The two thoughts are connected. It is hot and warm because it is sunny. And then the patient starts talking about the sun related to being sunny, right? So it goes on and on like that, flight of ideas. It moves from one to another, like a butterfly moving from one flower to another. Varieties of, or what could be seen in flight of ideas is clanging, punning and rhyming. Clanging is joining two similar sounding words like hocus pocus, for example. Punning is, an extra meaning to a word, like a double meaning word, using double meaning words, which sometimes you get in literature also, or usually seen in stand-up comedies. Rhyming, right? In poems, you have rhyming words. Clanging, punning, and rhyming, which are features of flight of ideas. They are all seen in mania. Night's move or derailment. Derailment is like the train going off the track. That's what it means. Or night's move. Knight's move means, you know what a knight is in chess? It moves in a L shape, right? So that's what happens to the thought in this one. The thought is going in one direction and suddenly it just goes in a perpendicular direction. It's like the train going off tracks. Okay, that's why it's also called derailment. Maybe seen in schizophrenia or mania. Overbreathing is talking past the point. That means if you ask the patient to talk about, let's say you show an apple and say, talk of everything about this fruit. The person will talk about botany, plants, trees, maintaining the plants, watering them, soil, everything except the fruit. So they'll be talking about related things, but they'll never get to actually talking about the apple. They never talk about the point, but they talk around the point. That's what it is. Sometimes the speech can be so muddled, it will be like a mixture of various unrelated words. So that is known as verbigeration or word salad. You know a salad, right? It's a mixture of different kinds of vegetables. So it's like that, the speech makes no sense whatsoever. So that can be seen in schizophrenia, especially schizophrenia with a lot of thought disorders such as hebephrenic schizophrenia. Neologism, neo means new, logism means words, so coining new words which do not exist in the dictionary, that is neologism. But it has some kind of personal significance to the patient. Only the patient understands the meaning of the word. So totally out of the blue, they'll just come up with a new word. So that is neologism. May be seen in mania, schizophrenia, or even in dementia. Thought content is what is present in the patient's thoughts. That's what it is. So as we discussed earlier, it could be obsessions, which are part of OCD, recurrent intrusive thoughts, which are distressing to the patient, but the patient cannot successfully block them. Phobias, irrational, exaggerated fear in excess to the expected reaction. You give a stimulus and the fear response is much more than what is to be expected for that particular type of stimulus. So there are different kind of phobias that can also be part of thought content. Overvalued ideas, as we discussed in the other day, attaching too much importance to one idea. If it becomes exacerbated, it can progress to delusion, which is fixed false belief in spite of evidence to the contrary. Even though you show evidence to the patient saying that it is not true, patient still continues to hold on to that belief. So that is a delusion. And as I keep telling you, if somebody is depressed, always check for suicidal ideas in thought content. You can also have hypochondriacal ideas in the thought content, as I have discussed earlier. It can also be anxiety related thought content, such as something bad is going to happen, for example. So all these are part of thought content. Perception. What are the perceptual abnormalities? We have discussed this: illusions and hallucinations. Classic example, rope in the darkness misinterpreted as snake, that is illusion. There is no rope, yet you are seeing a snake, that will be hallucination. Illusions may be normal, you and I can make a mistake. Hallucinations almost always abnormal, and according to the mode of perception, they can be visual hallucinations, auditory, gustatory, olfactory, or tactile hallucinations, according to the 5 sense organs. Depersonalization. The person's body appears to have changed in shape, form, or color. Derealization. The external world or the people around appear to have changed in shape, form, or color. May be seen in states of anxiety. May also occur as part of PTSD, as we discussed yesterday, right? Cognition. You can have various terminologies to describe the levels of consciousness in a patient. Somebody can be alert, that means completely awake and with you when you are interacting with the patient. Somebody can be confused, wherein the patient is somewhat disoriented and not aware of what he should be doing, what he should be saying, what time of a day it is, all those things. Lethargic or sluggish. The patient is alert, but the responses have slowed down. If you ask them to start writing, they will take a minute before they start writing because everything is slowed down. Difference between stupor and torpor. Stupor, as I discussed earlier, is alertness is there, but the patient is non-responsive to external stimulus and he keeps on staring at one particular point, maybe a feature of catatonia. Torpor is the patient is almost fallen asleep. Everything is narrowed down, the perception is narrowed, consciousness is narrowed, so hardly any response to external stimuli, and patient appears extremely drowsy also. That is torpor. Clouding of consciousness. Patient appears very, very drowsy. Not as part of sleep, not the pre-sleep drowsiness that you get to see normally, but because of some underlying condition, which can be a brain condition like encephalopathy, for example, or meningitis, or it could be the effect of a drug in response to some medication that you might have given, or it could be in response to some street drug that the patient has abused. Comatose, patient is completely unconscious and dependent on external sources for keeping the bodily functions going, such as ventilators, for example. Remember that clouding of consciousness, confusion, all of these could be a part of delirium, whereas only confusion can be a part of dementia, because in dementia, even though there is disorientation and confusion and loss of memory, it is happening in clear consciousness. That means the consciousness is not affected, the patient is not drowsy. Whereas in delirium, fluctuating consciousness, patient is in and out of alertness. Attention and concentration. Attention is, as I'm talking to you, you are listening and you are paying attention, right? If you have to sustain that same attention over a long period of time, as you are doing now through the course of this lecture, that will be concentration. So attention is a more immediate requirement. Concentration will be a more sustained focusing of mind on one particular thing. So that is concentration, which may be affected in both delirium and dementia. See, attention is more short term. I'll give you a sum, for example, a mathematical sum, right? And I'll ask you to solve it. You will take probably about 2 or 3 minutes to solve it. And the focusing on the sum that you are doing, that is attention. On the other hand, if I ask you to write an essay on air travel, for example, you will have to sit down and think about points for air travel, and you have to jot down, you have to make a structure of the essay, and you have to start writing from the introduction of the essay to the body of the essay to the conclusion. That requires a lot of attention, right? Sustained attention. So that will be concentration. So moving on to disorientation, as I keep on telling you, it is time first, then place, then person. That is how it is lost. So a person with dementia first may lose a sense of time. They may not know what time of the day it is, what day of the week it is, what month it is, what year it is. Then the place. They would not know where they are, which floor they are on, which area they are in, which country they are in, etc. Person, lastly, they will stop recognizing the people around them. They wouldn't recognize their own family members. Part of dementia can also be seen in delirium. Amnesia is memory loss. I hope you know that. So accordingly, it could be short-term memory loss or long-term memory loss. Memory itself is of different kinds. You can have semantic memory, wherein it is factual memory. That means all the things that you have learned in the medical course, all the theoretical knowledge that you have gained over the last 4 years, that is all part of semantic memory now. It has all moved into long-term memory. And remember, in long-term memory, the capacity is endless and you will never forget. Whereas short-term memory has limited capacity. There is only that much you can remember. And if you don't move that memory into long-term memory, short-term memory will be lost. So in long-term memory, you can get autobiographical memory, which is memory to do with your life events, what you did at a certain age when you entered the MBBS course. Procedural memory is skills-based memory. The first time you learn to ride the bicycle, for example, that is part of your procedural memory now. So it has become like an implicit memory. Implicit means you don't have to say the steps of riding a bicycle. You already know it. If you sit on a bicycle, you will automatically do it. So accordingly, there could be abnormalities of memory. Jamai Wu means even though the patient has been in this situation before, he can't recall. If you tell the patient, remember we met here 1 month ago, he will say, no, I don't remember. I'm seeing you for the first time. That is Jamai Wu. Deja vu is the opposite. Patient feels as though he has been in this situation before, sometime in the past. You know what confabulation is? By definition, it is falsification of long-term memory gaps. Falsification of long-term memory gaps. In the long-term memory, there are gaps where the patient has forgotten what has happened. For example, 10 years ago, when the patient was in university, studying in the university, he suddenly forgot one major part of that memory. Attending the classes, discussion with colleagues and teachers, he's forgotten all of that. So he will go about falsifying that memory. He'll be filling up the memory gaps with false information, which never happened. So I took part in a drama competition and I got the first prize during that stay in that university. Never happened. He never took part in drama, never got any prize. But he's filling up the memory gap by falsifying. So that is seen in Korsakoff's psychosis. Remember Wernicke's and Korsakoff syndrome, which can happen due to chronic depletion of thiamine, which can be a direct result of chronic alcohol dependence. if Wernicke progresses to Korsakoff syndrome, then you can have confabulation. Usually in dementia, short-term memory loss is there, but in Korsakoff syndrome, you have long-term memory gaps. Delusional memories may also be there, wherein a patient remembers some event, but the importance or the significance attached to that event may be completely delusional. Like, for example, he may say, I met my wife for the first time in that cafe about 12 years ago. The moment I saw during the entire meeting, now if I think back, I know that somebody was trying to harm me, which has never happened, of course, but the patient's interpretation of that memory can be very delusional. That's what it is, delusional memory. Apraxia and agnosia are neuropsychiatric terminologies. If a parietal lobe is affected, you can have apraxias and agnosias. There are different types of both these conditions. You can have constructional apraxia, wherein if you give matchsticks and ask the patient to construct a star out of it, he'll not be able to do it. Somebody can have dressing apraxia, which means patient is unable to do a simple task such as dressing up or buttoning the shirt. Cannot do. Seen in dementia also. They lose that ability. Previously learned motor abilities, even though there is no motor or sensory deficit, they have lost these abilities. That is apraxia. Idiomotor apraxia, that's another one, where you ask them to do a series of tasks like touch your nose, then touch the table, then pick up that book there. They'll not be able to follow these instructions through. Agnosia, on the other hand, is unable to identify sensory stimuli, even though they have learned all those things in the past. It was not there before. Again, parietal lobe lesions can cause agnosias. Somebody can have finger agnosia. They don't know which finger is which. They don't know the ring finger from the middle finger, from index finger, little finger, thumb. They have confusion with that. If you ask them to show index finger, they won't be able to. So that is finger agnosia. Writing on the body, like sometimes we write on the back, right? We write letters and ask them to identify. If you write even a simple letter or a number, they will not be able to identify. Agraphognosia, that's what it's called. Graphia is writing. So if they are unable to identify that, so that is agraphognosia. Prosopagnosia, do you know that? It means inability to identify familiar faces. Even though the person has seen the other person before, he is not able to identify the person. The facial features appear very different, therefore he can't identify. That's seen in dementia. Autoprosopagnosia is patient can't identify oneself in the mirror. If you show the patient the mirror, they'll say, who is this? So that is autoprosopagnosia. That is also seen in dementia. Anosognosia is a proper neurological condition where there is left-sided hemineglect, seen after stroke, cerebrovascular accidents involving the dominant lobe. If there is a cerebrovascular accident, the person will totally neglect the left side. He will be always like this, turning towards the right. It's as though the left half of the body does not exist. So that is anosognosia. Finally, insight. Partial insight. Either one of the two is absent. That is, either the patient believes he is ill but does not want treatment, or patient says he is not ill but willing to take your treatment. Full insight, where both are present, that means patient agrees that he or she is mentally ill and is also willing to take your treatment. Absence of insight is loss of both of these things. That is, patient believes he or she is not mentally ill and also refuses to take your treatment.